Hello and welcome everyone to our session today entitled Imaging Solutions for a New Reality, Made Possible, Optimized Workflow for Increasing Patient Throughput. We have a very interesting session for you, and we are fortunate enough to be joined today by Catherine Roy from Strasbourg, Ewoud Smit from the Netherlands, and Franco Orsi from Italy. The session will be organized in the following way. We will first have the talk and then have a live question and answer with all the speakers. As such, I strongly encourage all of you watching to ask questions in the chat box. Some of these questions will be answered during the presentations, and the most interesting queries will be addressed during the live question and answer. It's my pleasure to now commence this session by handing over to Catherine Roy, my colleague from Strasbourg, with her presentation entitled CT Imaging in the New Age. So, Catherine, you can start now.
Hi, everybody. It's really a great pleasure to be here to share with you my experience and to give you some information concerning this new CT unit. You know that the CT device is really the heart of any hospital, with multiple connection needed with our numerous clinicians, and interaction are needed also with our technologists. You can see here the multiple connection needed, and of course with a radiologist. Concerning the technologists, they need and they have really an easy-to-use hardware and software with many items available, and it works quite well. They love it. They need also a reliable device, and that's true. There was no breakdown during the 11 months of our experience. They need also an optimized workflow, and really ACE is almost in real time, and images are obtained in a few seconds. We never waited for them. Concerning the clients, that is the clinicians, they love new things and innovation, especially with the spectral imaging. I'm not sure that they understand anything, but their feeling is that really we are more confident with this new application. They want and they are fond of high quality images, as we are able to produce with the association of haze and the global illumination rendering. For example, you can see here amazing lung here on this 3D reconstruction with global illumination, and an amazing representation of the aorta with the bone around it. And if you look at this conventional acquisition, you can see that clearly the quality of haze is very good. They need also a high output, and the device is able to perform 15 cardiac scans during a period of 4 hours. It's easy for the machine, but not for the radiologist, of course. And for us, really, I believe that the right qualification and the good term to define this new CT unit is the versatility for all purposes. But I just like to focus my talk on 3 features who are commonly used in our department. It's subtraction, it's the spectral imaging, and of course haze is available for all applications. Just let me give you some information on the subtraction. It's really amazing. It's easy to understand. There is a subtraction between the non-contrast and the contrast acquisition. Iodine extraction map is obtained, and this is part is added to the previous contrast enhanced acquisition. So we obtain a color map and the iodine mapping. What amazed me the most is that if you look at those images, the coronal view, the conventional acquisition, and the iodine mapping, same level, you can see that clearly the border of the organs are very straight. There is no blurring. It's quite perfect. It is always the same thing for all organs. It's an entirely automatic process. It takes no more than 5 minutes. There is no impact on the workflow. You can get it in the 3 orthogonal views, and the subtraction is really perfect, as previously said. All phases are available, and a very important thing is that it's a virtual enhancement of the contrast uptake. You can decrease the iodine load for the patient. Let me show you a couple of examples. You are very more confident to diagnose if there is a slight or an intense enhancement or not enhancement at all. For instance, if you look at this patient, he underwent previously a partial surgery of the right kidney, and on the conventional acquisition, it's difficult to say if there is something wrong inside this part. But if you look at this, with the iodine mapping, clearly there's nothing inside. On the right part, so the patient has multiple cysts, and on the right kidney, there's something perhaps which is bad. But if you look at definitively the iodine mapping, it's normal. It's in a simple cyst or an hemorrhagic cyst. But if you look at carefully the left kidney, there's something heterogeneous in this part. And if you look at this on the iodine mapping, definitively it's a small tumoral process. This poor patient has a genetic disease, and the first examination was performed in November 2018, and everything sounds good on the conventional acquisition. And the following follow-up was performed in March, and you can see that definitively there is something bad in the posterior part of the right kidney, in the muscle. But it was previously seen on the iodine mapping at the time of November 28. So definitively you are able to have early evaluation, early diagnosis for a tiny enhancement. The second topic and the second features is the spectral imaging. So new one, the device has deep learning, spectral acquisition, performed on a single X-ray tube with a rapid KV switching. There is an automatic adaptive exposure, and the field of view is up to 50 centimeters. The acquisition can be done by helical or sequential. There is a deep learning reconstruction, and finally we will obtain the spectral analysis. Immediately or a few seconds after the end of the acquisition, you will obtain on the screen on the workstation 3 parts or exactly 6 parts. It's not too complicated in the reality. It's the same level with different information. Only in one click, and you have several anatomical data set available. If you look on the left of the screen, this is a monochromatic images, so you know that you can scroll through the KEV to obtain a better contrast or less contrast or increase. For instance, at this setup, a vascular study at 60, it's perfect for a vascular study. The purple one is the iodine map, and an interesting part is the virtual non-enhanced. That means there is no contrast at all. It is very important to consider this because you can avoid to perform an additional non-enhanced acquisition before the injection of contrast. You save time and you save radiation dose. And this one is a new one, gives you new information, effective Z and electronic density. And you can also, after put a region of interest have an evaluation of the modification of the intensity of the energy by scrolling through the KIV. It's a spectral curve. Let me show you a couple of examples. Really, those multiple tools are very useful to characterize and to quantify the abnormality. In this example, we have used the VNC. This is this part without iodine evaluation. We have used the iodine map, and we have used a spectral curve. We put a region of interest, and you can see that on the spectral curve there is a modification of the curve, meaning that there is an enhancement. And additional information is obtained in this. You have a new unit, a new evaluation of the iodine load in milligram per milliliter. It's not the useful unit, but we don't know today. Its threshold is really not available. It needs more research. It could be around 1 or 1.5. Another interesting part of the information is to have an evaluation of the effective Z. You have another value here, but this is really in research. But probably in the near future, you will be able to better characterize and better differentiate different components inside the soft tissue. And the third one, and not the least one, is the image quality we can obtain by HACE for all applications. This device is available for all applications. Just let me show you one example. This is a follow-up for an oncologic patient. She had a breast carcinoma, and the first follow-up was performed on the genesis, and you can see the liver, something seems good, and we performed the second follow-up 1 year later, after with HACE, and you can see the same level, the same patient. You can see that the image quality is very, very good, with less noise and a very high resolution for contrast agent also. But interestingly, this small detail, which is a small cyst, is available, and you can say that it's only a cyst. It was always seen here, but definitively you will be more confident to be sure that this is a cyst on this part. And if you look at the radiation dose, you can see that we have decreased the radiation dose. So less noise, better image quality, and more confidence for any diagnosis. In the department, we have performed a survey on different type of examination we usually perform between our two CT units, and you can see that with the new HACE reconstruction, we're able to reduce the radiation dose of around 40%. So to conclude with this new CT unit, I get that the three qualifications we can use is a versatility for many applications, reliability, and a fast workflow. This is the reality. So the final question maybe, is there any negative point? Yes, there is one. In my department, of my co-workers are fighting together to perform their examination of this new on this new CT unit. Thank you for your attention.
Thank you. Not sure everyone can hear me. Yeah, I hope so. Thank you very much, Catherine, for this great educational presentation. Please, for the audience, feel free to ask questions as we have time for questions in the end of the 3 talks. So don't forget to submit all your questions, and we don't keep them for yourself. And now we will move on to the second speaker, who is Dr. Ewoud Smit, who is working in the Netherlands in a city called Nijmegen. I hope I say it correctly. And he's got great experience in deep learning reconstruction in CT, and he's going to tell us all about it. So now you have let's launch the presentation.
Good afternoon, ladies and gentlemen. A warm welcome from Nijmegen, the Netherlands. It's a real honor for me to present here at the Canon Medical Systems Lunch Symposium. I would like to discuss the technical background and clinical applications of deep learning reconstruction in CT. I work as a radiologist in Nijmegen, and we have a great team of radiologists, radiographers, and medical physicists working together. We have a close collaboration with Canon Medical Systems, and as such, we have deep learning reconstruction available for almost 2 years now in our clinical practice. To be honest, I've always been a bit disappointed with iterative reconstruction. Images may look artificial and a bit plastic, as you may recall from your own experience. For example, here, the bowel wall, is this a bowel wall thickening? Are there tumor deposits, or is it just normal? Well, images may be improved with model-based iterative reconstruction, as you can see here. For example, in the shoulder region, where with model-based iterative reconstruction on the left, you can nicely appreciate this ground glass opacity. But the problem with model-based iterative reconstruction is that it's slow. A lot of calculations have to be performed on this model, which include the X-ray optics and information about the anatomy, the detector, and all this is combined to get great images at the cost of long reconstruction time. Iterative reconstruction was already introduced by Sir Hounsfield, but back then the computers were not sufficiently powered. So you may think computers should be fast enough nowadays to have fast processing times in clinical practice. Well, I was a bit surprised when I first found out, but where do you think that the reconstruction server should be located on this line? Well, it appears that reconstruction servers nowadays are already close to the computing power of a supercomputer, for example, IBM's Watson. So what do we want? We want images with excellent image quality, and those should have sharp edges, low noise, and a natural appearance. And this all should be available preferably at low dose with fast reconstruction time. And this is where deep learning reconstruction comes to place. In deep learning, input data is used and a network is trained to come to high quality images, as you can see on the right. And these high quality images are advanced model-based iterative reconstruction images, not the ones that we have in clinical practice, but scans that have been processed for days to weeks to get very excellent image quality. And then when this network is trained, it is applied in clinical practice on new scanner data. So the training is performed in the lab, and the application of deep learning reconstruction is in clinical practice. And the advantage of this approach is that this training is time consuming, but applying it in clinical practice is fast. But wait, isn't this dangerous, you may ask yourself? Could the algorithm introduce artifacts that may look like a tumor, or reduce and suppress metastasis, for example? Well, we have tested this technique for 3 months, where we reconstructed hybrid iterative reconstruction and deep learning reconstruction alongside each other, and we compared the scans, and we did not come across any of these artifacts. And after that, we used deep learning reconstruction for all patients and for all indications. So the trick here is that it's not that not one input scan is trained to a high quality scan, but instead many low-dose scans are simulated from the single scan. So the computer learns to reduce noise, and it does not learn anatomy or pathology. And Canon refers to this technique as ACE. So here's an example, a filtered back projection image. If we use hybrid iterative reconstruction, you can see that the noise is strongly reduced. If we then go to model-based iterative reconstruction, we see that the noise is further reduced, but images look a bit artificial. But with deep learning reconstruction, the images become natural again. If we compare hybrid iterative reconstruction to deep learning reconstruction, we see that there's noise reduction. And if we compare filtered back projection to deep learning reconstruction, well, then the difference is clear. So here's an example with hybrid iterative reconstruction on the right and deep learning reconstruction on the left in an obese patient with a BMI of 30. And we still see excellent image quality with a very natural appearance, even on the thin section data. And I especially value this technique in the pelvic region and, for example, for bowel walls. The pelvic region is traditionally a region where there are a lot of artifacts, but here we can nicely appreciate the sharpness and thinness of the bowel walls. And where in the past we had a lot of problems with adoption of iterative reconstruction, now radiologists, even the most conservative ones in our department, are very happy with the technique. And referring radiologists, they always value the image quality in our center. And it's not only, ACE is now available for all body parts. And here we see an example for the brain, where we have good image quality from the cranial region, all the way down to the posterior fossa, where there are traditionally a lot of artifacts from the skull. It's also available for CTA, for the whole body. And here we see an example of the carotids, where we have good image quality near the shoulder region, all the way up to the vertex. It's also available for brain perfusion, where we have much improved image quality, where we can even appreciate the basal ganglia. And this improved image quality also results in better image quality of volume rendering, for example. Our cardiac radiologists like deep learning reconstruction because the edges of the coronaries are much sharper, and so plaques are better appreciated. So how fast is it? Deep learning reconstruction is in the same ballpark as hybrid iterative reconstruction. The exact reconstruction times will depend on your setup, but we have timed the reconstruction times for brain CTs, and hybrid iterative reconstruction took about 27 seconds, deep learning reconstruction 44 seconds, and model-based iterative reconstruction nearly 3 minutes. Which means that model-based iterative reconstruction, it may take longer for a scan to reconstruct than to put the next patient on a table, and back then reconstruction queues may exist. So therefore we hardly used model-based iterative reconstruction. But now with deep learning reconstruction, we use it for all clinical applications in routine clinical practice. So what about radiation dose? Here we see the dose reports for the 6 months before the introduction of ACE and the 6 months after the introduction of ACE. And we see in real clinical practice that there's a dose reduction of about 40%. And it's very easy because it's included in the automatic exposure control. So it's just a matter of switching on a button. Here we see an example of a low dose chest CT, 0.5 millimeter sections in a patient with a cavitating pneumonia. And this scan was performed at a radiation dose of 0.1 millisievert, which is about the radiation dose of an AP and lateral chest X-ray. And the nice thing is that we can still appreciate the soft tissues. Here's an example of filtered back projection on the right, hybrid iterative reconstruction in the middle, and deep learning reconstruction on the left, in a patient with one arm alongside the body. And we're able to get still very good image quality at a radiation dose of about 1.8 millisievert, where you can nicely appreciate the pelvic region despite this hip prosthesis, and here, for example, appreciate the liver, when we see this smaller liver lesion alongside the larger one. So to summarize, deep learning reconstruction provides excellent image quality with fast reconstruction times and substantial dose reduction. So we can use this technique in routine clinical practice. Thank you for your attention.
Thank you very much, Dr. Smit, for the very interesting and convincing educational presentation. Please, again, don't hesitate to ask questions about the talks. And if not, I will have plenty of questions. And now it is my pleasure to introduce Dr. Franco Orsi from Milano in Italy with his presentation on Alphenix 4D CT in IO. So, Franco, it's your turn. Thanks a lot.
Dear colleagues, hello from Cabraiala Highland. In the next few minutes, I will share with you my experience in using Alphenix for DCT in interventional oncology. This is my institution where I'm working from since 25 years ago. In my department, we are 8 interventional radiologists with 8 technicians, 8 nurses, full of 8 anesthesiologists, and our main activities are very wide. We have a consultation office, outpatient care, since about 1,200 biopsy per year. The surgery, interventional procedures are our backbone, around 12 patients a week. We take care of our own patients in our dedicated beds. And then we have several multi-specialty tumor boards. And last but not least, around 15 procedures a week for emergency. Our main interventional radiologies are mainly focus on cancer. As you can see, we do chemoembolization, embolization, radioembolization, hepatic perfusion, percutaneous ablation, and also some benign disease such as high-intensity focused ultrasound and intracranial treatment for fibroids, uterine fibroids, vertebropathy, for a total amount of around 700 interventions per year. We have many ablation devices. This is one of the main concerns when you're organizing our activities, because we need a lot of space for locating our devices. So we have, as you can see, microwaves, generators, frequency generators, laser, and cryo. So we have some specific clinical needs. So we need more efficient therapies for reducing reassess, then a faster workflow for reducing the waiting list of our patients, and to achieve a safer approaches for reducing complications. Our activities is image guided, and so that's the reason why improving imaging will improve the outcome. That's the reason why since 2006 we installed a CT and angio and ultrasound in our cheapest way. That is a CT dedicated room with ultrasound and a portable fluoro equipment, together with equipment for general anesthesia, because we do in our standard treatment general anesthesia. So the many pro coming with these facilities are that we may achieve a more precise tumor targeting, having a panoramic overview of the treatment area, an immediate feedback of treatment, and also an early detection of possible complication that is so important because our patients are in general anesthesia. So we want just to finish our procedures when the procedures is really finished, so when the tumor is being completely treated. However, we have even some cons. There's mainly due to the fact that the CT, angio, and also ultrasound were not communicating together, and also the bed and patient movements are very complex and not reliable because there were different devices put together without any connection together. So that is why from April 2019 we installed the Alphenix for DCT in our new room. You can see the different positions of the CT and the beds of fluoro. And from April 2019, we achieved more space for medical devices, achieve a faster workflow, as you can see, better image integration between the different devices we use in our room, and allowing us to achieve a multidisciplinary approach. So I will share with you some interventions. This is a visualization of two different lesions. We do with super selective intrathecal delivery of beads charged with the immunotecan. As you can see, this is the step of the angiography. You can see the super selective angiography and the blush of the tumor here. So we achieve a CT scan, so you can see the CT during injection of contrast media. This image can be post-processed, allowing us to define the real vessel feeding the artery thanks to the embolization plan that allow you to have a reconstruction, 3D reconstruction, and overlap the image on the live fluoro, as you can see here. So we could be very safe and very precise when we deliver the beads, saving time and saving the no affected liver parenchyma. Then we, with the same way, we define the second vessel, the other vessels fitting the other lesions. Again, just put the patient through from the fluoro through the gantry, achieving the imaging. And again, with the embolization plan, the vessels fitting the artery were defined. As you can see here, overlapping the 3D reconstruction imaging on the fluoro, we define where the two vessels were coming from, doing the procedure in a very safe and precise way. And this is the CT scan on the end. You can see the lesional filled by the embolizing material. This is the day after, before contrast medium and after contrast medium. So the lesion were completely treated and the not affected parenchyma was avoided. Another procedure, very tricky procedure, is vertebral aorta. Is a vertebral into operative radiation therapy. In this procedure, we have to deliver energy into the metastatic lesion, the body of the vertebra. It is so important to be precise when we put the needle, as you can see here, within the body, because the prescripted dose have to be delivered in a 3D fashion. So the position of the cannula where the probe for radiation therapy is delivered has to be delivered in a perfect position. Here you can see the drill coming into the ball, then the cannula inserted. Sometimes we have to use the hammer for allowing us to put the cannula inside the bone. The CT scan at this time is so important to define the perfect position of the cannula before delivering the energy. And this is the simulation of the energy, the red dot here. At this time, the patient is treated with the radiation therapy. As you can see, this is the applicator, and this is the time where the radiation therapy is applied. No one is inside the room because of the risk of contamination. And then the procedure is closed with the cementoplasty. This is another procedure. This is a young patient with a lapse of liver metastasis after liver resection. Patient had two neurolapse, one here, one you can see here in 7-6. The patient was laid down in the lateral position. A CT scan is achieved before the procedure. You can see the two lesions depicted in the pretreatment phase, the lapse here and the huge lesion here. So by using a navigation system that allow us to have ultrasound and CT overlapping, we can treat even lesions that cannot be seen easily on ultrasound, but just putting an electronic landmark where the lesion is visible on CT. You can see this is the clip of the previous resection. So we have just to stick the needle until the landmark is reached, and then deliver the energy. The white spot is the energy that is ablating the lesion. So both the two lesions are treated, and this is at the end of the procedure, two huge necrotic area achieved. The first one and the second one. And the patient was awake with no more active lesions. Last but not least, we used to do radioembolization for liver metastatic disease in a very super selective way. The only way to do that is just having fluoro and CT in the same room. And as you can see, after we injected the macro aggregates charged with actinium, we may achieve this kind of mapping. The blue one is the liver we have to spare. The yellow one is the affected liver by the beads for the treatment, and the red one is the lesion itself. So we may achieve the volume of the three different areas. So the liver, the affected area by the beads, and the tumor. And according to this volumetric assessment, the treatment has been performed. And what we can call a theranostic, it means therapy and diagnostic. And so this is the SPECT-CT simulation the day of the simulation, and you can see the perfect overlapping of the simulation and the treatment. In conclusion, we may achieve better image quality for a better treatment control with the system, allowing for a better efficacy and safety for our patient. We can say that challenging procedures are made easier with the system, and the imaging integration allows also for a wider overview of our procedures. Multipurpose use of the system allow us to cover our wide interventional radiology case mix. I can tell you we can no longer do anything without Alphenix for the CT. It's really addictive. Thank you for your attention.
Thank you. Suppose I am live. Thank you, Franco, for this last and great presentation. All these tools are indeed very addictive, as you said. I have been asked to ask the audience to refresh your page so that the function of the live chat can be activated. So can you please do that? This is for the audience. And then I have been asked to wait for a few seconds or 30 seconds. So can you please refresh your page? All right. All right, so we have some questions from the audience. So maybe the first, one of the first question is probably for one of the two first speakers. Have you had any issue with deep learning reconstruction removing anatomical features? So maybe who wants to take this question?
I can answer it.
Yeah, please.
Yeah. Thank you very much for your question. Yeah, we were also a bit afraid of that when we first received the technique, and we systematically reconstructed the hybrid IR, reconstructed the scans with hybrid IR and deep learning reconstruction, and asked all radiologists when reviewing the scans to compare both techniques. And we did not come across any of these issues in the first 3 months that we reviewed both techniques, and we haven't seen any indications after that as well. So we were afraid of it at the start, but we were convinced later on in the process that no structures are removed.
Thank you very much. Another interesting question is that deep learning reconstruction improve diagnostic performance. Sorry. Does it
only, Professor Roy?
Does it only look good, or does it really improve diagnostic performance?
We can both answer.
Maybe you take this question, or Catherine, whatever.
You can. Can you hear me? Yes.
Yeah, we can. I cannot see you, but maybe the audience.
Okay. Concerning this issue, really, we have many cases with patients coming from oncologic patients and coming simultaneously, and for each patient, we have found that with haze, the image quality was really better, and metastases were always clearly found and better assessed with haze than previously found with ECR2020. So I guess that haze offer a better image quality with really improve the diagnosis, and you can be more confident for your diagnosis with A. I'm sure that with our experience.
I also agree with Professor Roy. It makes you more confident, and images are also more fun to read. The abnormalities are more clear, the less disturbing artifacts. And even the oncologists notice it. If you have a multidisciplinary meeting, even oncologists notice that these scans are much sharper and clearer than the previous ones or the ones from referring hospitals.
Okay, we move on to the next question, as we have a lot of very interesting questions from the audience. This is for Franco, a question for Franco. How long is the learning curve for the interventional procedures shown in your lecture? And how long was the learning curve with the AI demonstrated?
Very good questions indeed. Yes, of course. I mean, at least at the beginning of my experience, so I needed a lot of time for learning the procedures because I didn't have enough confidence with the imaging coming from different sources that were not connected together. So, of course, the learning curve of the new system, and I mean in the system where the CT, angio, and ultrasound are connected together, is much shorter because you have all the imaging information in your hands. And because our activities is mainly based on imaging, of course, when you have all the images on your hands, the procedures is made easier. Because you are confident in what you're doing, because you can see in real time, in a very panoramic view, what you're doing. So in terms of efficacy and safety, the image quality is really affecting. So even the learning curve is much shorter when you have all the imaging connected together.
Thank you so much. I think we have time for another question, so I will ask some of my questions. A question for Catherine Roy. Catherine, how do you decide which patient you will put on the spectral CT and which patients you will decide to use conventional CT? How is the workflow organized in your institution? I suppose you have several CT.
Yes, sure. It's quite easy to answer because all oncologic patients were explored with spectral imaging, because for each of them, I found that we increase the contrast uptake with this type of new acquisition. The main problem is that the radiation dose is nowadays is higher than with haze, but in the last version and the last uptake, it will be similar. So for each oncologic patient, I get that spectral imaging will improve and the diagnosis performance.
So, and you really do not get a non-contrast
yes,
CT
that's right.
anymore.
Only for portal phase. Only one portal phase, and you can avoid with VNC. You can avoid an enhanced conventional acquisition. Only one portal phase.
Thank you very much. Well, I think it's time to I think we have no more time for any question. I would like to thank the organizer, and I was delighted to moderate these sessions. Thank you for the nice talks, very informative of these innovative tools. Thank you for the questions from the audience again, and I wish you a good afternoon.
Bye-bye.
All right. Thank you. Bye-bye.
Thank you so much.